Hello. Thank you for the opportunity to share some of the work that my team at Advocate Christ Medical Center, Department of Internal Medicine, has been working on recently. My name is Janu Kurian, and my colleagues, Dr. Chandler Walsh and Dr. Matali Roy, would like to share a unique etiology to a common patient presentation of bilateral lower extremity weakness. So, as we all know, lower extremity weakness is a common complaint that brings patients to the hospital for evaluation. The workup is very vast and involves the consideration of various different etiologies. These can include drug-induced, electrolyte-induced, genetic, infectious, inflammatory, metabolic, neurologic, rheumatologic, or even oncologic, just to name a few. So when considering the cause of lower extremity weakness in a young patient with no significant past medical history, it's important to consider malignancy of the spinal cord among our differential. This is a condition that remains indolent for a very long period of time before symptoms start to arise. It's important to address this specific etiology because poor outcomes are associated if diagnosed late. So we present a case of lower extremity weakness that is actually secondary to spinal cord drop metastasis, which was suspicious for high-grade neuroepithelial tumor with B-core gene alteration. This type of tumor was first identified in 2016 and is typically present among young children, and there's very limited data present regarding the presentation in adults. The etiology is poorly understood. However, what we do know is that these tumors are characterized by expressing immunopositivity for SAT-B2. So in our case, we had a 40-year-old male with no significant past medical history come into the hospital with 6 weeks of worsening bilateral lower extremity weakness, which resulted in paraplegia as well as sudden bowel and bladder incontinence. He reported no family history of neuromuscular diseases or any kinds of malignancy. He denied any weight loss or deconditioning given the quick progression of his illness. He also denied any recent infections, vaccinations, or change in his appetite. He also noted no recent changes in his weight loss or any types of family history with similar symptoms. He also noted no change in his bowel or bladder habits prior to the day of his admission. When he was admitted to our hospital, initial diagnostic workup consisted of laboratory studies significant for a positive ANA and RNP. We then did imaging, which consisted of MRI of the brain, C-spine, thoracic, and lumbar vertebrae. So as you can see in this bottom left-hand corner, we have the brain MRI, which was significant for a 14 mm enhancing lesion of the right cerebellum and a hemorrhagic 2.6 centimeter lesion of the midbrain. The MRI C-spine, also shown here, showed severe cord compression at the C6, C7, secondary to a 2.2 centimeter by 0.7 centimeter mass. And we can also see the MRI of the thoracic and lumbar vertebrae here, which was also notable for 3 enhancing masses of the spinal cord. These were present at C7, the T3, T4 region, and the T11 region, and this caused severe compression of the spinal cord. The MRI was also notable for diffuse leptomeningeal enhancement of the cord concerning for carcinomatosis. So in terms of management of this patient, the initial symptomatic treatment included dexamethasone and levetiracetam. This was given as dexamethasone 4 milligrams every 6 hours and the levetiracetam every twice a day. We also did a C6, C7 laminectomy with decompression of the intradural tumor with duroplasty, and we did biopsy for next-gen sequencing. The surgical pathology report was done and notable for densely cellular neoplasm with high mitotic activity. We also did immunohistochemistry, which showed a strong diffuse positivity for the SAT-B2, which I mentioned earlier is a hallmark for this type of malignancy. Grading was notable for WHO grade 4 and PD-L1 expression with a CPS score of 1. For the management of this tumor, we did a VP shunt was placed, and we had the initiation of 3000 CGY radiation to the whole brain, thoracic, and lumbar spine. We then made plans for initiation of systemic chemotherapy after discharge. So in essence, we would really like to convey the point that patients presenting with lower extremity weakness should have a very extensive differential diagnosis regardless of their presenting comorbidities. This is very important in young to middle-aged adults, where missing their true diagnosis could cause a significant loss in their quality of life. Although common patient presentations can help guide our differential, they really shouldn't be used to rule out a diagnosis unless we have objective measures that point elsewhere. The high-grade neuroepithelial tumor with B-core gene alteration is a rare neoplasm, and the etiology is still poorly understood. Only through detection and further evaluation can we develop different types of treatment. It's important to consider this type of rare neoplasm as a cause of bilateral lower extremity weakness because it's associated with high mortality. We found a review of 24 cases of this specific type of tumor, and their overall survival after 48 months was found to be 50%. Therefore, making this diagnosis can greatly improve the prognosis of our patients. And also, further evaluation of this tumor will be helpful because there's currently no definitive guidelines involving the treatment of the high-grade neuroepithelial tumor with the B-core gene alteration. We hope that further evaluation can help guide different screening guidelines that can be made for the future. Thank you for listening to our presentation. The references for our topic can be viewed here.